Welcome to a rare but potentially fatal complication in the dental office and how to treat it. Another comprehensive presentation produced exclusively by Southwest Oral Surgery, continuing education at your fingertips. My name is Brian Oglander. Disclosures for today's presentation, none. Let's begin with the patient case. We have an 8-year-old Bosnian male, first visit to the dentist. Within 10 minutes into a prophylaxis, the patient notices his lip is swollen. Another 5 minutes goes by and the hygienist notices the patient has lost consciousness and is unarousable to voice or touch. There's no significant past medical history and no known drug allergies. On physical exam, the dentist evaluates the patient and notices the heart rate at 178, blood pressure of 70/30. The patient is unconscious, unarousable to voice or sternal rub. Upper and lower lip is swollen. The cheeks show erythema. Cardiovascular, the patient's tachycardic. He has a high heart rate. Respiratory exam, there's poor respiratory effort, apnea. What do you think management of this patient should be? Benadryl intramuscular, steroid intramuscular, Benadryl PO, epinephrine injection intramuscular? No treatment, as this condition will likely resolve on its own. If you answered epinephrine intramuscular, you're correct. This patient is suffering from anaphylaxis. Intramuscular epinephrine should be given first in anaphylaxis. It should be given in a concentration of 1 to 1,000 or 1 milligram per 1 cc. The adult would get 0.3 milligrams or 0.3 cc's. In a pediatric patient, they would receive 0.01 milligrams per kilogram or basically 0.15 milligrams. Epinephrine should be given in the lateral thigh. There is no contraindication for epinephrine administration, IM. There's minimal negative effects. Only epinephrine will relieve the laryngeal edema, hypotension, and shock of anaphylaxis. What is anaphylaxis? It's a life-threatening condition marked by cardiovascular collapse, generalized interstitial edema, and bronchospasm. It may occur through immune and non-immune mediated, such as anaphylactoid mechanisms. Anaphylaxis itself is a Galen-Coombs type 1 IgE mediated reaction involving release of vasoactive mediators. Incidence: 25,000 cases per year, 0.004 to 0.0115 cases per dentist per year. Morbidity in all these cases of anaphylaxis is roughly 0.5 to 1.3% of all cases. Anaphylaxis in the dental office is very rare. Potential systems affected in anaphylaxis: we've got the cutaneous system, soft tissue of the mouth, tongue; respiratory, namely bronchospasm, wheezing, difficulty breathing; cardiovascular, the most important being hypotension or a decrease in blood pressure; and gastrointestinal, basically related to a food allergen, including nausea, diarrhea. Anaphylaxis is likely when one of the following conditions is met. In the face of an unknown allergen, if we have involvement of the skin, mucosal tissue, or both, and respiratory compromise or reduced blood pressure. With a likely allergen, if we have two or more of the following: involvement of the skin, mucosal tissue, respiratory compromise, reduced blood pressure, persistent GI symptoms, or if we have a known allergen and reduced blood pressure. I can simplify the definition of anaphylaxis: an allergic reaction involving two or more of the previous organ systems or profound hypotension. Remember, anaphylaxis is an IgE reaction. It's a severe, potentially fatal systemic allergic reaction that occurs suddenly after contact with an allergy-causing substance. Contact with latex, a bee sting. Think of the patient who has a peanut allergy and ingests peanuts, versus what's called anaphylactoid or non-IgE mediated. This is a severe, potentially fatal systemic allergic reaction that occurs suddenly after systemic exposure with an allergy-causing substance. Think of the patient who's having a CT scan and gets an overwhelming amount of IV contrast. That is a systemic exposure. Incidence of substances causing IgE-mediated anaphylaxis during the perioperative period. The greatest causative agent is latex at 22%, followed by antibiotics given, then followed by other, namely local anesthetics. With regard to latex anaphylaxis incidence in the population, it's usually higher in healthcare workers, much greater, up to 68% of children with spina bifida related to frequent surgeries, less than 1% of the general population in the U.S., or about 3 million people. There's no literature supporting that latex in dental cartridges causes production of anaphylaxis. Most reactions to latex are delayed type 4 reactions, the contact dermatitis. Local anesthesia-related anaphylaxis is extremely rare at less than 1%. Though reactions to amides and ester local anesthetics can occur, usually the allergic event is related to 1. The antioxidant, namely the sodium metabisulfite, and local anesthetic containing epinephrine cartridges we would use in dentistry, or If an ester local anesthetic is being used, the allergic reaction is due to a metabolite of the ester, PABA, which is similar to a preservative paraben, which is found antimicrobial in multi-dose vials. If you have a patient who's describing to you in the office that they're allergic to local anesthetics, your 4% articaine without epi is probably your safest. What do we do with somebody who we suspect is having an anaphylactic reaction? First, we begin with the ABCs. We perform our primary assessment. We look at their airway, we look at breathing, we supply supplemental oxygen. We should have a blood pressure cuff in our office to check blood pressure. Then we'll look at the symptoms. Are we simply seeing cutaneous symptoms, hives, itching, rash, or are we seeing swelling of the tongue, throat? Is the patient complaining of wheezing? Are we dealing with an airway issue? If we're looking at simply cutaneous type of a reaction, Benadryl by mouth at 50 milligrams is what we want to give. If we've got a patient who we suspect is having difficulty breathing and the tongue is becoming swollen, we need to activate 911 immediately. We need to draw up epinephrine at a concentration of 1 to 1,000, and we need to give that IM at 0.3 milligrams or 0.3 milliliters. The most common cause of death in anaphylaxis is airway obstruction. Wheezing is common. Remember, we have our albuterol, which is a beta-2 agonist, as part of our drug kit. We can have the patient take 2 to 3 meter dose inhaler puffs. Cardiovascular collapse is the second most common cause of death. Duplicate down. Treatment may require multiple doses of epinephrine. That's why patients who use their EpiPen, or if we were to give a dose of epinephrine in our office, we need 911. The patient needs transport. Many times these patients will require another dose of epinephrine. The down portion is a supine position. We want our patient flat, supine. It's better than an upright position, which is associated more with cardiovascular collapse. Quick focus on epinephrine. We must have that in our off. Remember, the manufacturer's product information for all local anesthetics lists positive pressure bag valve mask and epinephrine as a required armamentarium in the event of an allergic reaction. Epinephrine, sympathomimetic amine. What does it do? It acts on alpha-1 receptors to increase blood pressure. It acts on beta-1 receptors to increase the heart. It acts on beta-2 receptors to relax bronchioles. In other words, to treat bronchospasm. Epinephrine is a vasoconstrictor. It inhibits its own absorption. Therefore, we must give it in the lateral thigh. We do not want to give it sub-Q. What's our armamentarium? What do we need? We need to have an ampule or a vial of epinephrine in a concentration of 1 to 1,000 or 1 milligram per 1 ml. We need a 1 cc syringe with increments of 0.1 so that we can measure out our epinephrine. And we need a 1-inch 25-gauge needle. The keys to giving an intramuscular injection. We want to give our injection at 90 degrees. We do not want to pinch the skin. That's only going to increase the chance that we're going to be further away from the muscle. There's no need to aspirate, as there are minimal large vessels in the area that we're injecting on the lateral thigh. Remember, the lateral thigh has a faster uptake versus the deltoid or your upper arm. That's why the injection should be in the lateral thigh. And we need a needle length to get epinephrine into the muscle. That's at least 1-inch needle length for the child and 1-inch needle for the adult. We have the option of keeping the EpiPen in our office, ready for immediate usage. It's easy to use and it's easy to store. However, it has to be purchased in 2 packs at a cost of upwards around $300, and you need to keep both a pediatric and adult EpiPen, which increases our cost. The needle length is fixed at 1/2 inch. Therefore, not every time somebody's getting the Epi auto-injector, the medication reaching the muscle. It has a 2-year expiration, and it's often difficult to practice with unless a trainer is available. Here's a picture of different needle sizes and lengths. Your needle at the top of the screen is about the length for your Epi auto-injector. Your needle in the middle is a 1-inch needle. That's what we want to have available for both the adult and pediatric patient. And your needle at the bottom is a 1.5 inch length needle. We may want to consider that for certain patients, especially because a lot of times if we were giving this medication, we're going to be giving it through clothes. Supportive care. So what else do we do besides epinephrine? Remember, we need 911. Remember the acronym duplicate down. These patients usually need additional doses, and we want to keep them supine. We monitor for the need for CPR, and we supplied supplemental oxygen with a face mask or nasal cannula. Conclusions. Epinephrine must be part of an emergency drug kit. There is no contraindication to epinephrine intramuscular. We want a concentration of at least 1 to 1,000. We want to give our injection in the lateral thigh. Remember, epinephrine is the only agent that will relieve the laryngeal edema, hypotension, and shock of anaphylaxis.